I think it's
Okay.
starting now.
Say recording in progress. Yeah. There we go. It started. Cool. So my name's Jordan. First half of this session, I'm going to be just teaching on some orthopedics. We'll go through a few cases, and hopefully you can all get to grips with it. So we're going to start with a case. So we have a 45-year-old gentleman who arrives in ED complaining of rapid onset right knee pain. On examination, the knee is hot, swollen, and red, and he reports he's never experienced this before. He reports no other symptoms. There's reduced range of motion on bow flexion and extension. During your history taking, he reports drinking 30 units a week in beer consumption and is sexually active with his long-term partner. He mentioned his father suffers from a disease which causes his skin to look bronze, which is related to iron absorption, but he can't remember the name. A joint aspirate is undertaken. So what do you guys think your big differential should be? So this is acute monoarthritis or the red hot joint. What could be causing this presentation? Pop anything in the chat.
Septic arthritis is your big one.
Yep, that's number one. You always want to consider that one. Always consider septic arthritis in an acute monoarthritis, no matter what. Anything else? Yep, so you want to consider gout, so a crystal arthropathy. Yep, septic arthritis, gout, pseudogout. Any others?
Reactive arthritis.
Yep, so you want to say reactive arthritis. It's less likely in this gentleman because he has a same regular sexual partner, but you might have like 18-year-old comes back from Ibiza and, you know, has a classic triad of symptoms. Do you know what the triads of symptoms in reactive arthritis are? Is there a good rhyme for them?
Oh, is it the one where it's like can't see, can't climb a tree, something like that?
Yeah, can't see, pee, or climb a tree.
Yeah,
so it's a HLA B27, and it's urethritis, conjunctivitis, and arthritis, usually following STR dysentery. Okay. Another one is hemarthrosis.
Sorry, is that specific to reactive arthritis? Or did you say it's all the
No, that's specific to reactive arthritis.
Okay.
And it's just, it often comes hand in hand with someone who has B27 other syndromes, like Angstbon, that kind of stuff. Hemarthrosis is rare, but you want to consider it. What condition might lend itself to hemarthrosis? So bleeding into the knee joint.
ACL rupture.
Yeah, so you tend to get more synovial fluid rather than bleeding, ACL rupture. So if you're bleeding a lot, what could cause you just to bleed a lot generally? To be more predisposed to bleeding?
Specifically just put something in the chat.
Oh yeah, so hemophilias, yep. And what's something that as doctors we give out patients like a lot to take home? And
anticoagulants?
Yes, anticoagulants as well. So yep, the other is reactive arthritis, and the final one we want to consider it's less likely because this is a single joint rather than multiple joints, but you want to consider an inflammatory arthritis like rheumatoid arthritis. It can present acutely in a single joint before you get a more established pattern of swollen, painful joints, stiffness worse in the morning, and an insidious presentation over time. So I'm just going to talk quickly about septic arthritis. So it's something that is commonly missed. It carries a mortality rate of around 10%. Risk factors tends to be at the extremes of age. So young kids, very old people, and often those who are immunosuppressed or have a history of chronic conditions like diabetes. And it tends to be more subacute onset. So it actually kind of gradually happens over a week or 2 weeks. So something you want to consider with this gentleman here is actually this has come on very sudden onset. So you want to keep your eye on septic arthritis, but it may not be the cause. And also you want to check for recent surgeries because someone may have a joint prosthesis which has infected the joint. And also do a full history in terms of drug history because IV drug use can also lend itself to increased risk. There are often quite common organisms which cause septic arthritis. Do you guys know any of the common causative organisms?
Staph aureus.
Yep, S. aureus, yep. And is someone sexually active? Gonorrhea, nice, well done guys. And then gout, we also really want to keep an eye on for this. Do you know what, rather than the knee, more common effect? metatarsal pharyngeal joint, MTPJ. And you need to distinguish gout from pseudogout. You need to look at the crystals under a microscope. However, if you did a X-ray of someone's knee who had pseudogout, what might you see that could help you? And it's only seen pseudogout as opposed to gout. Chondrocalcinosis, exactly, because pseudogout is a condition caused from calcium phosphate deposition, whereas gout is caused from the buildup of uric acid. So if we look back at this SBA, here are some differentials based on what we said. You do this synovial fluid analysis and you see this image. What do we think is causing this man's presentation? First of all, what are the crystals showing? Do you know how you describe those crystals? Yep, so you've got needle shapes. Do we know if they're positive or negative bifringent? So if I told you that the light that's being shined onto these crystals is yellow, so they're negative because it's not refracting the light that's shining on it. And here are some big clues in the question. He's a big drinker. The hemochromatosis I just threw in there as a bit of a red herring. So hemochromatosis is a risk factor for pseudogout. However, it's unlikely this gentleman has hemochromatosis because the mechanism of inheritance is autosomal recessive. So it's possible he might have pseudogout, but it's less likely than him actually having gout given his history. So yes, it's gout. Just for completion, this is what the crystals look like in pseudogout. So you get these more rhomboid shapes, which are blue under light. So we're going to talk a little bit more about gout. So it's an inflammatory arthritis due to persistently elevated levels of uric acid. So when we think about the causes of gout, one potential cause could be an increased intake of urate in the body. So what do we think might be responsible for increased intake of urate? So what kind of foods are high in urate? Red meat, yep. Anything else?
Seafood.
Yep, some saying seafoods, exactly. And what about this guy? What risk factors does he have, which we mentioned in his history? It's a drink that has really high in purines, which uric or urate. Yep, alcohol. So beer specifically, but alcohol. Yep. The other is when we're producing quite a lot of uric acid in the body. It's a bit of a harder one, but does anyone know any conditions or things which might cause high levels of uric acid to be produced within the body?
Just throwing Crohn's out there.
You can throw it out there. Unfortunately, it's not correct. Think about okay, what cells might have uric acid in them? Sorry. CKD, correct kidneys. I'm not sure. I'm going to go through this because it's a bit of a hard one. But I think hemolysis. So red blood cells have the urate in them. If you're going through a lot of red blood cells, you're going to release a lot. And a few things with bone marrow. Just keep those on your horizons, but they're not very common causes of gout. And the final one is reduced excretion. So that's where CKD comes in, renal impairment, hypervolemia, and certain medications. You know what medications might cause gout? Diuretics, yep. Any specific type of diuretic specifically?
Yeah, thiazide diuretics,
Yep.
right?
Thiazides are the big ones. The other ones you want to keep an eye out for are salicylates, so aspirin, and some immune suppressant drugs as well. So if we put all those risk factors together, the people you tend to see who have gout are old men who are a bit obese, drink a lot, and they might have some comorbidities and maybe a family history as well. In terms of the drugs, thiazides we mentioned, salicylates, allopurinol. You don't want to start allopurinol acutely, and I'll go over that in a sec, and cyclosporin, it's immune suppression. So I just gave that away. You all probably saw it, so I'll just go through it. So in terms of treating gout, you tend to give NSAIDs or colchicine acutely. So someone's first presenting with gout, you will give them an NSAID or colchicine to dampen the immune response, to dampen the inflammation essentially. And you want to wait until the inflammation is settled before you give them allopurinol. However, if someone's on allopurinol because they've got established gout and they come in with an acute flare-up, they stay on their allopurinol and take that regularly. Does that all make sense? there's loads of past med questions on it, so if you're confused, you can practice that. And also, of course, you want to encourage their lifestyle modifications. Things to be aware of colchicine, it is first line, but it can have a slower rate of action, and it also causes diarrhea as a side effect as well. Okay, SBA2, so you get an orthopedic bigwig, hands you an x-ray to interpret. Based on this x-ray, what do you think the nerve at highest risk of being injured is? So you can pop the answers in the chat. And yes, thank you, Prina, yeah. Don't give NSAIDs in asthma or peptic ulcer disease. Okay, so we've got B, median nerve. Yeah, correct, guys. So the median nerve is the nerve most likely to be affected here. So I'm going to go through each of those nerves, which fractures are at risk of damaging those nerves. So if we look at all these nerves here, so first of all, the radial nerve, it tends to be affected when you get a mid-shaft fracture of the humerus. The other thing is when someone's crutches are quite poorly adjusted, or if they fall asleep on a night out with their arm over a chair, called Saturday night falls, which is a great name. The median nerve, as we'll go over, we've got here a fracture of the distal radius, which is where the median nerve is most vulnerable. The ulnar nerve typically happens with elbow dislocations because it's at its most vulnerable point along the coronoid process. So I've just remembered I've got arrows for these. So that's where the ulnar nerve is weak. And the axillary nerve you typically get from surgery, and you get this paresthesia over the regimental patch, which is here. And the anterior interosseous nerve I threw in there, it's a branch of the median nerve which leads at the elbow. And if you want to test it, get patients to do the OK sign, and they won't be able to do it. It will look a bit like that instead. So before we get on to this fracture in particular, what kind of terms have you guys heard to describe how two pieces of bone can relate to one another in a fracture? So how can we describe fractures? What terms have you heard?
If it's an open or closed fracture?
Yep. So an open fracture will be one which actually you can see the bone, so it's actually directly like coming out the skin, or closed is where the fracture maintains itself within the body, and most fractures are closed fractures. Yep. Anything about how the two pieces of bone relate to one another after a fracture?
Displaced.
Yep. So yep. Very good. Any others? Good. Okay, I'll go over, I think you mean green state, but I'll go over that in a bit. So here's just, so when you've got fracture bones, you can talk about the two fragments. So displaced and translation are pretty interchangeable forms. And angulated is when the bone's at angle, shortens, and rotated is rotation. Two views, so you get a lateral view and an AP view, to see the amount of displacement if there is in the fracture. So what fracture do we see, and is there any displacement? Yep, so you've got the eponymous name for it, but how would you describe this fracture? Okay, so you've got displacement dorsally, yep, so you always talk about the more distal fragment in relation to the proximal fragment. So you've got dorsal displacement and you've got fracture of the radius. So volar displacement is when the distal part of the bone moves towards the palm of the hand, and dorsal's away from the palm of the hand. So you're right, we've got a distal fragment that's moved, so we've got dorsal displacement and a fracture of the radius, aka a Colles fracture. So a Colles fracture is a really common fracture you'll see in any. It's classically when someone falls on an outstretched hand. Almost exclusively the people that get it are old people who have quite poor bone quality and osteoporosis, and they just fall on ice. It's really common in winter, and get a Colles fracture. In terms of the treatment, you tend to give bisphosphonate, so bone strength and vitamin D, and you also will go through your surgical management. So you always want to check median nerve damage, and you go through reduction on anesthetic, and you put them in a plaster for 6 weeks and then rehabilitate. The only time you will do surgery is if you've got a really complex fracture. So it's comminuted, which means it breaks up into lots of different fragments, or it's really severe. So they say something called dorsal tilt, which is essentially how much the distal fragment's tilted away. But just something to keep in mind, usually they don't go in for surgery, it's just if it's really complex. And it's also called, if it helps you remember, a dinner fork deformity, just because the way the wrist looks when you lay it down on a table. So the general process I find best to go through interpreting an ortho x-ray, and it's a really common thing you'll have to do, not only when you're on your rotation, but we had to do this as an OSCE station, is using, as always, an ABCDE approach. So the first step is adequacy. So what kind of things would you be wanting to talk about in your adequacy? What kind of things do you always mention for any x-ray as well?
If the x-ray is like well done and you can actually see like the contrast and things like that.
Yep, that's very good. So you want to make sure that you can see all the bones involved. What things do you always start off with any x-ray? Like, really basic thing, never to forget. Check the name, date of birth, check the date as well, because patients often have multiple x-rays. Yep, really good. Okay, so patient details, what views you have. Do you have a lateral view? A classic thing that orthopedic surgeons do is give you an x-ray and it's just one view, and the first thing you might say is, can I have a lateral view, please? And is there good penetration? So next we'll look at the bones and the joints. So you want to go through essentially dividing up the bone. Most people use, whether it's proximal or distal, they find it a bit easier. You can use the diaphysis, metaphysis, and epiphysis if you want to be really technical. And you also want to look at the bone density and maturity. The key reason why you want to do this is because you want to make sure that the mechanism of injury fits with the pathology you're seeing. So if it's an old person who's got osteoporotic, then it might explain things. But let's say it's a young child who's got quite an odd fracture, you might want to consider what kind of conditions. Let's say you have a child who's having repeated fractures. What things should you be thinking about? So you keep coming into A&E.
Would a kid with lymphoma have often fractures?
So kids with lymphoma, Prino, what do you? I'm not sure. Kids with lymphoma would have frequent fractures. They'd have frequent. I'm not sure on lymphoma. I was thinking more to do with what their bones would look like when you look at their kind of bone density and quality under imaging. Prino, I can't hear you now. Maybe type it in the chat. I'm sorry. Okay, so I'm thinking, have you guys heard of osteogenesis imperfecta? It's a condition where you have quite brittle bones, and frequently these children are raised for safeguarding concerns because they're coming with frequent fractures, and they might, if you look under X-ray, they'll have really poor bone density and many previously healed fractures. Cool. Next is the soft tissue. So what are you going to look around the bones at?
Not sure how well you see it on an X-ray, but like swelling around the joint.
You can see swelling around joints. It's really important, especially in something like rheumatoid arthritis. You'll see lots of swelling around the joint. And they might have effusion, calcification. Always look for foreign bodies as well. Sorry, here are just some different fracture types that you can comment on. So the top ones are complete fractures, where it goes the entire length of the bone, and the bottom ones are incomplete fractures, which tend to happen more in pediatric populations. And then finally, you just want to look at everything else, so fixation devices, and maybe consider some additional views. So next is management of fractures. Does anyone know the headlines that you say when someone's like, how do you manage a fracture? What are your steps? There are 4 steps to managing any fracture. You do sometimes want imaging. That's what I'm thinking. I'm thinking in terms of what you would do. So someone comes into A&E, they have a Colles fracture, they have a fracture neck of femur. Yep, so you want to reduce. What's something you want to do before you reduce? Reduce is step number 2.
Stabilize.
Yeah, so stabilize or resuscitate. Yep, so that includes analgesia. What else might you want to give someone? Let's say they've got a open fracture. So
Antibiotics.
Yeah, antibiotics, exactly. Let's say you're anticipating they're going to go into surgery for a couple of days and they're going to be on wards, not moving around. What else do you want to give them?
Prophylactic diets.
Yep.
Or something.
Exactly. The next step is reduce. And then after you've reduced it, what do you need to do? So you might reduce it in, let's say, the ED department, just to align the bones a bit closer. What's the next step?
Fixation.
Yep, so yeah, stabilize or fixate. And then finally, you want to rehabilitate them. So resuscitate, we talked about analgesia, antibiotics, VTEs. Reduction, you can do open or closed. So closed is when you don't, open them up in surgery, just do it in ED department or anywhere else. Stabilize, fixation, and then rehabilitate. You might want to consider an underlying cause of the fracture. Let's say someone's osteoporotic, you might want to investigate them with a DEXA scan, and always gives things like smoking cessation advice, because smoking causes the perfusion of your bones, because you're in the bone marrow, to be a bit poorer. So it means you heal your bones a lot slower. Okay, so we're going to practice interpreting some fractures with some upper limb fractures. This is just like a good little handy slide, how to approach one. Just try to trace the outlines of each bone, look for a change in continuity, and look at the angles as well. So first one, does anyone know what this is? And if you don't, how would you describe it? So if we have a displacement here, would we say this is a dorsal or volar displacement? Remember, you're talking about the distal fragment in relation. Yep, exactly. So you've got a volar displacement. Is there a fracture you guys can see? If so, which bone's a fracture on? Yep, and radial fracture. So does anyone know what this is called? So you've got a radial fracture and volar displacement. Yep, it's the Smith's fracture, exactly. And it's usually falling backwards on an outstretched hand or falling with your wrist flex like that. The one
Sorry,
Colles. Yep.
Could you kindly re-explain the whole like volar and dorsal
Sure.
displacement? We didn't quite get that.
Yeah. So volar is when the distal segment is like towards the palm, and dorsal that way. So as you can see, if the hand's here, the distal segment has moved that way. That's how I remember it.
We'll ask again at the end, because our internet's just like you're kind of lagging for us. No worries, we'll ask at the end.
Okay, so we've got another one. So what's the one on the left? And if you don't know the name, the eponymous name, you can describe it as well.
Sorry, just before you do these, can you hear me?
Yep.
So the one thing I wanted to add is with wrist x-rays or hand x-rays specifically, when you're presenting them, have like a first sentence that makes you just sound slick, and in it what you just want to know is whose this it's and why they've had it and which hand they write with. So it just sounds off and sets the pace so much better if you're like, so this is a right wrist x-ray of like Janet Smith, she's 46, presented with a 4, she is right-handed, continue. But yeah, keep going.
Yeah, no, that's definitely a point that you need to, it's always good to like say the salient findings. Okay, so the x-ray on the left, does anyone know what it is? And if you don't, could you describe it? Where's the fracture? What is the fracture? Is it complete, incomplete? What's affected? So you've got radial ulnar dislocation and an ulnar midshaft fracture. So that is a Montague fracture, correct? Sorry, that's not Montague fracture. It's a Galeazzi fracture. I get them confused as well, and I'll give you a helpful mnemonic. So, and then on the right side, so what bone's fractured? So you're right, sorry, Basil, you're right, but it's for the right side. So on the right, you've got Montague fracture. I'll go through on the left, sorry. So Galeazzi is a distal third of the radius fracture, and you get dislocation of the distal radioulnar joint. And you usually get it from a direct blow. And on the right side, you've got a Montague fracture, which is where you get a fracture of the proximal third of the ulnar, and you get dislocation of the proximal head of the radius. And that sounds like gibberish, I know. The best way to remember this is Glasgow Rangers or Galaxy Rovers, that's the way to remember it, as a football team, and Manchester United. So you just remember two football teams. In Galeazzi's, the fracture happens with the radius, and in Montague, the fracture happens with the ulnar. That's just the best way to remember it, because it's really easy to get the two confused. Anyone know what's going on here? So remember, trace the bony contours. See if there's any disruption that you can see. If it helps you, I could give a made-up history for this person. Like 30, yep, so you've got first metacarpal, base of the first met. Fracture, do you know what it's called? Typically, it's a fracture involving people who get in fights. So have a flex. Punch someone. It's a Bennett's, yeah. It's also sometimes called a boxer's fracture, to be fair. Grand, that's where it is there if you didn't see it. Okay, this is a tricky one. It's typically missed as well. Often people will present with kind of wrist pain. They get an x-ray, no pathology. They go home and they'll come back a couple of days later saying that they're still in severe pain. Good, scaphoids. This is a scaphoid view, which is specific for you to try and see scaphoid fracture. So you can see it there. It's usually from falling on an outstretched hand or in a contact sport. This is where you will tend to get the most pain. Hand like that, or you telescope their thumb inwards, it will generate a lot of pain, and it's commonly missed. So to treat it, you put them in a futurist splint, a specific type of splint, and you refer to ortho, who will usually cast or fixate, depending on how complex the fracture is. And that's just a little bit about how scaphoids come about. So we'll quickly just do an SBA, final SBA on neck and femur fractures. So you have an 82-year-old lady who's brought in after experiencing a fall in public and has tenderness over her left hip, her left leg's shortened and externally rotated. She enjoys an independent lifestyle and spends most of her days in the garden. What's the most appropriate management? So you can pop your answers into the chat. Okay, so you got a vote for hemi, you got a vote for total hip replacement. Got another for DHS. All right. Oh, we've got one for cast and mobilization. So you guys are hitting all the letters. I've really split the field here. Okay, so the answer is total hip replacement. The two key questions is Masana's hip fracture, like what was the mechanism? So did they fall? Do they have diagnosis of osteoporosis, osteopenia, that kind of thing? And also, what was their functional baseline? It's really important for the surgery. And I will go over that. Is what a total hip replacement looks like. And it's because it's got an acetabular head as well as a nail going on. So it's like both components of the hip, whereas a hemi doesn't have the acetabular component. So we're looking at a neck and femur. You can divide up your fracture based on the area where it's affecting. So you have either an intracapsular or an extracapsular. Everything that's intracapsular is before the intertrochanteric line. And extracapsular is the intertrochanteric line or subtrochanteric, basically. So you've got nice dividing lines on that as well. And then once you've worked out where the fracture is, you work out whether it's a displaced fracture or an undisplaced fracture. So if it's undisplaced, i.e. the two parts of bones have not really moved apart from one another, and the person's fitting well, like a young person, you just tend to put in cannulated screws. It's just an internal fixation method. You don't want to give a young person a hip replacement because it's a really tough procedure and it will need to be replaced again probably in the future. If the patient's really unfit, then you tend to just give them a hemiarthroplasty. And usually it's quite morbid. They will die of something else before that replacement needs to be fixed. If they have a displaced neck of femur fracture and it's intracapsular, what are the two things you can give them? They were on that SBA.
Total hip replacement.
Yep, total hip replacement or a
hemi also.
Yeah, or a hemi. And you want to give a total hip replacement to someone who's really independent. They're not cognitively impaired and they're medically fit for anesthesia. And the total hip replacement, it does have a higher rate of dislocation, but it allows a much greater range of movement. So someone's a ballroom dancer, someone likes going out in their garden, you want them to keep up their lifestyle and you'll accept that risk of having them needing to get a replacement of that THR. If they're, not cognitively there, they don't move around a lot, give them a hemi. So if it's a stable intertrochanteric fracture, there's an image of it, what do you give them?
Dynamic hip screw.
Yep, a DHS. And the way I always try to remember it is you have to kind of think about where the fracture is and how the screws like keep all the hips, like the component in place. And that's because it's intertrochanteric, so you need to also stabilize the head of the femur as well as like the main shaft. And then if it's subtrochanteric, reverse oblique, so really complex intertrochanteric, what do you give them?
Yeah. Intermedullary nail. This one.
Yep, correct. That's it, guys. That's NOFs, like in a nutshell. I'm going to pass it over to Jess, who's going to carry on the ortho theme with some complications that can happen.
Just before Jess starts,
Oh, sure.
I just want to make sure you guys completely get this whole idea for hip fractures and scaphoids as well. Do you guys know why it's particularly important to diagnose those fractures? Like, why is it for scaphoid, if you don't see it the first time, you tell them to come back a week later? And why is it like every time an old person falls, you really check that they haven't got a hip fracture?
Because the scaphoid and the neck of femur, as Amelia said, avascular necrosis, because it's like retrograde blood flow.
Yeah, perfect. So they get a retrograde blood supply, so you're higher risk of necrosis if you don't do something about their fracture. With the hip fracture specifically, the total hip replacement it replaces the actual trochanter in the head, and then it also replaces the surface of the acetabular. So the reason why you do that in an intracapsular one is because you have utterly screwed their blood supply from both directions. Like, it's within the capsule. So you need to deal with both sides of the blood supply and replace both things. If you just replace the head, the acetabulum is still going to die, and vice versa. If it's extracapsular, you can get away with doing a dynamic hip screw or an intermedullary nail for exactly that reason. And the reason why you decide between a dynamic hip screw and a nail is based on like where it is along the shaft. So can you see in Jordan's image, you kind of need some space along the shaft to put your dynamic hip screw in. And most of the support is like along the plane of the neck of the femur. So that means that when they're walking about on it and when they're moving, the like dynamicness of the screw is what supports the two extra bits. And whereas if you have like a fracture a bit lower down, you won't have the space to put the dynamic hip screw in, so you need the longer nail along with the actual like femur as well to support it. Does that make sense? If it doesn't, I'll go over at the end. But I used to be like, this is just random ortho tools and screws, but there's a logic as to like based on where the fracture is, why they use what, and it's much easier when you get that. Cool, all yours, Jess.
Yours, Jess. Yeah, I'm going to stop presenting now. Yeah.
Oh, sorry, I think I just took
You've
control.
already taken control.
Let me just upload mine. Okay, can you see that?
Yeah, we can.
Okay. All right, so I'm going to be going through some kind of post-op complications. So let's spend the day in the life of a surgical F1 who's on call. So your bleep goes off and we're called to the orthopedics ward. And this is our first patient. So I'm going to be sort of basing this around some SBAs because from the feedback, it sounds like you guys enjoy SBAs. I guess, shall I read it out? I'll read it out. So Mrs. H is a 62-year-old lady who underwent a toe tape replacement 7 days ago. 2 hours ago, she suddenly became short of breath and developed chest pain. The pain feels sharp and is worse when she breathes in. Her OBS are as follows. I'll let you guys read that. Her ECG shows sinus tachycardia and her chest X-ray is normal. What is the next best investigation for Mrs. H? This is quite a classic question.
Is it CTPA?
Yeah, good thoughts. Well, why do you say CTPA? What do you think's going on?
Because you suspect a pulmonary embolism after a surgery, so you just want to check that she has one.
Yeah.
And if she doesn't, then you do a D-dimer.
Yeah, she's tachycardic and tachypneic as well. So
Yeah. Oh well, there's two voices coming from one person. Okay. Yeah. No, that's exactly right. So in a post-op patient, there's always a risk of venous thromboembolism, so DVT or PE. So she's become really short of breath suddenly, which is classic of a PE. She's developed pleuritic chest pain, which is worse when you breathe in because the pleura are irritated. So other things that irritate the pleura, like pneumonias, can also cause pleuritic chest pain. And then she's also tachycardic, and her ECG shows sinus tachycardia. So some people have said a D-dimer level, and so I'll talk about this in a minute, but if we were sort of having a low suspicion of a PE, we would check the D-dimer first. But with this patient, she has a really high Wells score, which we'll go through, which is the reason why we go straight to the CTPA. And we're not going to be doing an ABG necessarily, or it's not our next best investigation because she's not, particularly hypoxic, and it's quite a painful thing to do. If she was quite like hemodynamically unstable, then we definitely would. A VQ scan is not anymore the recommended scan to do, and then coagulation studies we might also do, but it's not sort of the most appropriate next step. So pulmonary embolism. I'll just talk through this in the interest of time, but symptoms and signs you guys seem to know. So tachypnea is like the most common thing you can get, tachycardia too, and we spoke about pleuritic chest pain. You can get hemoptysis as well. If there's like a big blood clot, it can cause infarction and like necrosis of the kind of lung tissue, causing some bleeding. But again, this isn't that common. You get signs of respiratory distress as well. We'll talk about that in a sec as well. So signs of respiratory distress is something you always want to look for in your A2E assessment. So what sorts of things are we talking about there? What signs would you be looking for? This is like under breathing in your A2E.
She has a high rest rate.
Yeah, exactly. Anything else on our sort of look of the look, feel, listen measure? Accessory muscle use, pursed lip breathing, high rest rate. Yeah, perfect. Also like nasal flaring. You can get you said accessory muscle use. The patient might be tripoding, which is where they kind of like leaning forward, resting on their arms to try and make breathing easier. And then signs of a DVT as well, so like a red swollen leg. And then investigation. So the purpose of the chest X-ray is to rule out other differentials. We're not really going to see a PE on a chest X-ray. We're going to do an ECG as well. Do you guys know like what the most common ECG finding is in a PE? It's also a classic SBA. So S1, T3, Q3, which I've got a picture of soon, is a finding you can get in PE, but this is the kind of trick question because sinus tachy, like Basil said, is the most common finding. So about 40% of PE patients. Oh yeah, perfect. So about 40% of patients have a sinus tachycardia. And then the D-dimer. So it's got a good sensitivity, which means that most patients with a PE will have a raised D-dimer, but it's got a low specificity, which means that it's raised in like loads of other things. So any form of inflammation, like malignancy, like Preen said, after any surgery, it's going to be high. And then the CTPA is our like diagnostic test. A VQ scan is not like the first line investigation, but in some places, if you don't have access to a CTPA, you might do one. If someone's got like an allergy to contrast, because in a CTPA we inject them with contrast. If they've got renal impairment as well, we don't want to give them contrast, so we could do a VQ. This just to show you is the S1, Q3, T3. I think it would be quite mean to get this in an exam, but what it means is you have like a deep S wave in lead 1, a deep Q wave in lead 3, and T wave inversion, which is like a sign of right ventricular strain. But it's also, found in other conditions, and not that many people with a PE have this. And so the Wells score, which I mentioned, we calculate for any patient with a suspected PE. I don't think you really need to kind of learn it off by heart. It's quite intuitive. But the reason that we went straight to a CTPA on our patient is because she had quite a high Wells score. So do you guys know what the cutoff is for when you would sort of have a high suspicion of PE based on the Wells score? Yeah, 4, perfect. So there we go. Yeah, there we go. So a PE is considered unlikely if you have 4 points or less. And in this case, we do a D-dimer as a kind of safety net just to check. If the D-dimer was raised, then we might be thinking there might be a PE, so we'll do a CTPA. If, however, if however the Wells score is more than 4, say 5 or above, we'll just go straight to a CTPA. So in terms of the Wells score itself, if if an alternative diagnosis is less likely than a PE, which basically means our top diagnosis is a PE, that automatically gives you 3 points. So you only really need like 1 or 2 of these other features. So for example, in our patient, she had, we had high suspicion of a PE, so she gets 3 points. She also had tachycardia, which gives her 1.5 points. So, ignoring the fact that she just had surgery, so she was immobilized, she already qualified for a CTPA. So if you just remember that and a couple of the other points, that should be more than enough. And then if we can't do the CTPA immediately, you want to kind of treat them in the meantime. So another question. So Mrs. H's CTPA shows the following, and she is hemodynamically stable. What is the best treatment option for her? And if you're not too sure of the answer, perhaps, which ones can we rule out? Okay. Someone said D. D.
Is it?
Yeah.
I was going to say it's 3 months of apixaban because it's a provoked PE, but because they're not hemodynamically unstable, you don't need to go down the route of thrombolysis.
Yeah, perfect answer. So anyone who, no, that's fine. We'll talk through it. Oh, there we go. Yeah. So just as Liam said, someone got a question?
If they're provoked, is it 6 months of a DOAC?
So if it's provoked, it's 3 months. So in a provoked,
and then unprovoked, sorry.
Yeah, exactly. So if it's provoked, that means there's been a trigger. So something like surgery, recent long haul flight. We only treat for 3 months and the reason is because you sort of have eliminated the risk factor. So, this patient's not going to, be on a long haul flight for 3 months, that risk's been removed. So we only need to treat for 3 months. But if, however, a patient has had a PE and we don't know why, there might be like an underlying malignancy or something, that risk is still potentially going to be there a few months down the line. So we treat for longer just to cover for that. And the first line is like a DOAC, so apixaban, rivaroxaban, dalteparin, low molecular weight heparin, which is typically second line. But to be honest, like NICE isn't too specific about which anticoagulants you can use. So as always, begin with your A to B assessment. And then, like we've said, if the patient is hemodynamically stable, we give oral anticoagulation. So usually a DOAC or a low molecular weight heparin might be second line. And like we said, so provoked only treat for 3 months because they're no longer at risk. If it's unprovoked, we treat for 6 months and also investigate for an underlying cause. So that might be like a clotting disorder or malignancy. So yeah, and then if they're hemodynamically unstable, that you guys seem to know, the first line thing we do is thrombolysis. So we give like a clot busting drug, which usually feed in through a catheter to the site of the clot, and it will break down the clot. However, with thrombolysis, there is quite like a high risk of bleeding. So does anyone know any contraindications? So when you wouldn't perform thrombolysis?
Is it pregnancy and malignancy? I can't remember. I think there's a few others, but I'm not sure.
Yeah, I think malignancy is one. I'm not too sure. Yeah, I mean, you probably wouldn't in pregnancy.
Hemorrhagic stroke?
Yeah.
Which came one of the two.
Yeah. No, that's perfect. It's actually both. So any sort of like internal bleeding, if they've ever had a hemorrhagic stroke, or if they've had an ischemic stroke less than 6 months ago, you're not going to want to give thrombolysis. Yeah, if they've got like a tumor in the brain, if they've recently had surgery, any sort of clotting bleeding disorders, if they're allergic to the drug, that that's always like an easy answer. If they've got an allergy, aortic dissection too. So just know a few of those. And then if we can't thrombolyze or if it's ineffective, then we might get the interventional radiologist to kind of fish out the clot. Yeah. Okay, that's a good point, Brina. So if you've had a recent ischemic stroke, you don't want to risk it refusing and bleeding and turning hemorrhagic. Pregnancy isn't a contraindication. Okay, good to know. And then there's these IVC filters. So what these essentially are is this like metal cage you put in the inferior vena cava. And the idea is it stops any DVTs from traveling to the lungs, because most PEs do originate from a DVT. But I think that like the evidence base for that isn't so strong. Okay, let's move on. So patient 2. So Alex is a 23-year-old man who fractured his right tibial shaft in a snowboarding injury. This was repaired 2 days ago with an intramedullary nail, and his right leg is now in a cast. Since the operation, he reports increasing pain in his right leg despite being given morphine. There is paresthesia of his right toes and pain on passive movement of the knee and ankle joints. His obs are stable and pulses are palpable. So what is the next best step in Alex's management? This again is quite like a classic question that could come up. B? Anyone else got any thoughts? B as well. Okay, this is also a kind of mean wording, because I've said the next best step rather than, like what's going to be the ultimate definitive treatment, which definitely would be B. However, this is compartment syndrome, and you always want to do your sort of you always want to do like your simple measures before you go and take them to theatre and do the fasciotomy, which we most likely are going to do. So compartment syndrome is like a limb and life-threatening emergency. And essentially, it's just raised pressure within a compartment, typically like in the leg or the tibial shaft fracture or a supracondylar fracture. And because you get this raised pressure, you decrease the perfusion to the muscles and the nerves in that compartment, and you can just get necrosis within like 4 to 6 hours, I think it is. So it's, a huge emergency. The features, so it's all the P's. Does anyone know any of these?
Is paresthesia one of them?
Yes, it is. Anyone know any others? Pain, perishingly cold, paresthesia. Yeah. I don't think I included perishingly cold, but I should have done. So pain, that the fact that our guy was on morphine and he still had pain is like a big red flag. And it's especially on movement, including passive movement, paresthesia, pallor. If the pulse is weak or absent, that's like a late sign. That's really bad, and so is paralysis and perishingly cold. And then the diagnostic test, it's kind of strange. You kind of put these needles into the compartment and you measure the intracompartmental pressure. And if the pressures are more than 40 milliliters of mercury, that's diagnostic. So like, you wouldn't necessarily see anything on an x-ray. And then management, so you always get help. And then step 1 is to, if they've got a cast on, remove the cast, loosen the dressings, and then we are going to take them to theatre and do the emergency fasciotomy. Yeah, Liam?
What causes the raised pressure within the muscle compartment? Like, what is it? Just trauma, or?
Yeah, so this is like a complication that it's like always after a fracture, or nearly always. So yeah, I think it is like presumably the trauma, the swelling, edema. If Brina or Jordan want to add on that, please do. But yeah, like the classic history is going to be after a fracture of a long bone. And then we give IV fluids as well. Does anyone know why? Okay, so when you have sort of like necrosis or death of any muscle, you're going to be leaking myoglobin out into the bloodstream. And yeah, perfect. So if this like gets in the kidneys, it can block the tubules. It's like nephrotoxic, and you can get acute kidney injury. You can even get renal failure. So to try and like prevent this, we give loads of IV fluids too. Okay, our next patient, Sally. So the nurses also ask you to review Sally, a 70-year-old lady with chronic kidney disease on hemodialysis, who underwent surgery for a femoral shaft fracture yesterday. You've been asked by the nurse to check up on her. She is no longer alert as alert as she was before. On examination, her pupils are 2 millimeters bilaterally. And here are her OBS. So which medication is most likely to be responsible for her presentation? This is also a bit tricky. So if you can just rule out options as well, that's good. All right, has anyone got any thoughts? Or if you don't know the answer, what do you think the kind of picture is? B. Fentanyl. Yeah, exactly. So it's some sort of opiate overdose. Yeah, this is really tricky because I have included fentanyl, morphine, and tramadol, which are all opiates. The answer is morphine, because this is one that's renally excreted. Tramadol and fentanyl are largely like hepatically excreted, partly renally as well. But the sort of learning point of this is just never give morphine very cautiously in a patient with renal failure, because they're not going to be able to clear it as well, and it's likely to build up and cause toxicity. So opiate intoxication. Like I said, morphine's renally excreted. So in patients who have chronic kidney disease, it can take like up to the half-life is up to 50 hours compared to 3 to 5 in a patient with normal renal function, which is significant. So much higher risk of opiate toxicity. And the picture that you get, so like respiratory depression, so their respiratory rate will go down. You get pinpoint pupils, so like bilaterally small pupils. Got a picture, you can see they're quite small here. And a reduced GCS as well, so they're going to be quite drowsy. And do you know what the treatment is for opiate intoxication?
Naloxone?
Yeah, perfect. Naloxone. I suppose this could potentially be like an A to E station. It would be a bit mean, but IV naloxone. You can also give it IM, but ideally IV. And it's got a rapid onset and a really short half-life, so you have to basically keep giving it like every minute or two until the patient's respiratory rate increases enough. And you're always going to want to kind of consider like calling anaesthetists if someone's got a reduced respiratory rate too. In the interest of time, let's just go talk through this. So some other causes of bilaterally constricted pupils. So we've talked about opioid overdoses. Yeah, of course, ABG as well. Organophosphate poisoning as well. So in acute medicine, you sort of have to learn this on past med, like the kind of antidotes to all the different types of poisoning. So just be aware that if someone's got pinpoint pupils, we're going to be thinking opiates or organophosphates. If you get like a hemorrhage or stroke of the pons as well, you get pinpoint pupils, and pilocarpine constricts your pupils. That's a treatment for glaucoma, so more 5th year. I've got a few more minutes, so let's go on to the general surgery ward. So your bleep goes off again. And we meet patient 4, John. So John's an 80-year-old man who developed difficulty breathing one day after an emergency laparotomy for small bowel obstruction. He's known to be a heavy smoker. And on examination, he looks breathless. His obs are as follows. On respiratory examination, there's reduced air entry bilaterally, and there's fine inspiratory crackles at the bases, and the lung bases are dull to percussion. What is the best next step in his management? This is also like a very typical kind of post-op question that you could get. And again, if you can even just narrow it down to a couple, that's also good. C, high flow oxygen. So we haven't actually been given his oxygen saturations. We might consider giving him oxygen too, although if he's a heavy smoker, I guess he's also at risk of COPD. Celia, did you want to say something?
Yeah, I was just going to ask about with COPD patients about being really careful of how much oxygen you give them. Yeah,
exactly. So we'll have like a lower kind of have a lower range of your target sats. Is he septic? So he's got a high temperature. Something else to note is that it's quite normal actually to have a fever the day or two after surgery because all the kind of inflammatory mediators released. But we always do want to be thinking about possible sepsis. You know, our patient's tachycardic and has a temperature. Okay, so a couple of people have gone for D, which is the correct answer. So this is, to be honest, if you haven't heard of this, it's kind of hard to know what it is, but this is ATELECTASIS, which we'll talk through in a sec. So the first step that you always want to do is reposition the patient to an upright position, and then we're going to go on to consider option A, which is like chest physiotherapy. We'll talk about that in a minute. So what is ATELECTASIS? So I've got a picture here. It's basically partial collapse of the small airways. So what happens is, it's quite typical after surgery. You get accumulation of these bronchial secretions in the alveoli at the bases of the lungs. There's like several postulated reasons why. Some people say like decreased surfactant production, or like if patients in pain, they're not breathing as deeply, or there's compression of the alveoli. But anyway, you just get these secretions which essentially obstruct the small airways, and so you get these like very small areas of collapsed lung, typically at the bases, which can cause difficulty breathing. And ATELECTASIS is actually really normal in most patients post-operatively, but you know, it can be worse in some patients who have the following risk factors. So increased age and smoking, like our patient was, are kind of the biggest risk factors for ATELECTASIS, or if they have pre-existing lung or neuromuscular disease. Also, if they've had a long surgery, if they've been under general anaesthetic, that's a risk factor. And then if the patient's also in pain post-operatively, they're not going to be breathing as deeply, so you're at increased risk. And as well, if they're kind of lying down without being moved around a lot, that's another risk factor. And so how does it present? So we get dyspnea, you can get increased respiratory rate and reduced SATs. It's kind of controversial whether or not the fever is due to ATELECTASIS or a post-surgical thing. But it's usually within 1, if not 2 days post-operatively. And it can be asymptomatic in, you know, healthier people. And it's a clinical diagnosis. And then in terms of treatment, so always the kind of basic measures first, we position the patient upright. We then want to consider chest physiotherapy. And this can also be done like pre-operatively to try and prevent ATELECTASIS. And that's just like deep breathing exercises. And yeah, just increasing their like tidal volume. Pain control as well, because if a patient's in pain, they're not going to be breathing properly. And then we want to stop his cigarettes because that's a risk factor for future episodes. I'm aware of the time, so I'll just quickly rush through this. This is an X-ray of ATELECTASIS. It looks quite a lot like right lower lobe collapse. So if you can see, so if the normal lungs, the left one, and then on the right heart border is kind of obscured, and you've got this triangular opacity, we would describe this as, which is just collapse of part of the right lower lobe. So yeah, to be honest, it looks exactly like right lower lobe lung collapse. And the last thing I really quickly wanted to talk about was what can cause a fever post-operatively. So can anyone pop in the chat any thoughts? Or turn on your mics. Infection. Yeah, where can the infection be coming from?
From the op site, so like the wound hasn't been cleaned properly or things like that.
Yeah, wound infections, definitely one to consider. Anyone else got thoughts? Yeah, general inflammation, exactly. So like the first day or two after surgery, it's very normal to have a fever. Any other thoughts, any other sites of infection? If not, I'll move on. Okay.
If you don't do anything about the atelectasis, what other infection can they get?
That's a very good point.
Some respiratory infection.
Yeah, exactly. Pneumonias. So you can get like a hospital-acquired pneumonia if that patient's been in hospital for a few days. You can also get like aspiration pneumonias after surgery. So this is a really useful diagram from Teach Me Surgery, which if you haven't seen that website, I would recommend having a look. So these are kind of the days after surgery, what sort of causes of fever you're at risk of. So day 1 to 2 after surgery, it's the wind, so respiratory sources, so pneumonias, like Celia said. Day 3 to 5, we're thinking about water, so UTIs. Most of these patients will have catheters in, especially if they're not very mobile. So that's a potential source of infection. And then day 4 to 6, we start thinking about walk. So DVTs, PEs, also fever is quite a common sign of that. And then again, like Celia said, so a wound infection, it's going to take a bit longer to happen. So surgical site infections, also thinking about abscesses and collections. And then, to be honest, I think this option can happen at any time. So you can think of like, what did we do, or wonder about drugs. So drug fevers. So it's quite common after a lot of drugs to have kind of an adverse effect of a temperature, especially a lot of the analgesia used in surgery. You can have reactions to blood products. Yeah, there's a lot of this on PassMed. To be honest, like none of these rules are very strict. It's just, be aware of what's most likely to happen pretty soon versus a while after surgery. In day like 1 or 2, it's unlikely to be a wound infection. And then also at any point, if you've got a cannula or an arterial line, you can get a bloodstream infection from that as well. And then I've also just popped this on. You guys can have a read. We'll upload the slides. You can classify the post-op complications as immediate, early, intermediate, or late, depending on how long after surgery they occur. And a lot of it is just kind of common sense, thinking what's going to happen very quickly versus what's going to take longer to happen. But yeah, I won't go through that now. But yeah, thank you guys so much for all your contributions as well. Let us know if you've got any questions. We'll hang around, or if you want anything re-explained. We'd love some feedback. Let us know what you want next time, what we could have done better. Yeah, or if you have any general questions about 4th year as well, we'll stop the recording.
Something I wanted to mention about the PE stuff, it's not high yield,